Algo.
¿Me escuchó?
¿Me escuchó? Sí, súper bien. Súper bien.
Toma acá.
Toma.
No te entiendo nada.
Ahora, ahora sí. Ahora.
No, no te entiendo nada. No, no te escucho.
Yo te escucho súper bien, pero tú no. Te escucho también, pero...
Acá adentro, pero afuera nos... Ya, María, prueba los dos micrófonos ahora. Acá, le subiste el botoncito. Se escucha chicharrear, no se escucha como mi voz.
¿Qué cosa?
¿Aló? ¿Aló? No me estoy escuchando. ¿Aló? 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 Algo está pasando. Maca, 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 maca. Algo está pasando. Ya, ahora no. Como que- como-
Pero antes no era altavoz estable, ¿me acuerdas? Antes tú me decías que era uno que se llamaba Scarlett.
A lo mejor escuché. No escucho nada. No. Debería escucharse el tío. Pruébale. ¿Aló? Lo apagué. Ay, perdón. Lo que no sé es que yo me escucho. Yo tengo el micrófono al mando, debería escucharme. ¿Me entiendes? Mm. Aló, aló. No estamos recibiendo el sonido.
El conocimiento y el acompañarme, ¿cierto? Eso dentro de, ¿cierto? De llegar a esta medicina al estándar internacional y todo eso. Tomar unos minutos para contarles, ¿cierto? De reconocer a alguien que y ayer muy al caso, porque ayer lamentablemente falleció el doctor Pediatría. El doctor Enrique falleció hace 90 años. Quiero pedir que hagamos un reconocimiento, una historia de vida que está muy cerca de lo que es la cultura diversificada. Es algo que se formó en la Universidad de yo puedo explicar lo que trabajó por 50 años. Yo por los primeros años, del año 54, se dedicó a la cardiología. Cuando yo me dijeron que dedicarte a la cardiología, se quedó allí, desarrolló técnicas, fue el primer hemodiagnóstico. Participó en la primera cirugía corpórea de Chile y de Latinoamérica. Se hizo en de impulso a la cardiología nacional. Fue el año que él nombrado maestro de la cardiología chilena. Lo que vemos hoy en día del Centro de Reconocimiento Internacional, cardiológico, se debe a toda la tenacidad, el cariño, se hizo tiempo, el esfuerzo, o bien algún servicio, de técnica, de mentora, que fue, y no es que sea muy enana por mucho tiempo, que fue especializada afuera, volvió, siguió dando un empuje y interés en que el hospital público, se hicieran algunas cosas que se hacen en otras partes del mundo, con el mismo estándar, la identidad, ¿cierto? Que esta medicina altamente compleja llegar a cada uno. Así que, una cosa que para él, creo que es enseñanza. Como digo, 50 años por acá, todos se aprendió, por acá, por acá, por la cabeza, y lo recordamos hoy muy de la mano de estar escuchando para ver cómo la tecnología estamos unidos a ser profesionales. Así que ese es el espíritu del cargo y agradezco a cada uno que sigue presente. Lo hoy en día. Gracias.
Bueno, siguiendo con lo que nos convoca, que es la reunión del servicio de pediatría, también fue organizada por la nefrología, y un tema muy interesante, un viaje a través de la historia del raquitismo, para el cual contamos con la presencia del doctor Dieter Hafner, que William también bienvenido con nosotros. We appreciate your presence with us. Really. And now your presentation to my friend Francisco Cano, and so welcome with us. Se puede contar que todo el año, profesor de biología, jefe de departamento de mitología pediátrica, farmacología pediátrica, metabólica pediátrica, neurológica, pediátrica, es coordinador del Centro para Enfermedades Clínicas de la Reunión, del Centro de Enfermedades Raras de la Universidad de y es un experto en temas de genética, en enfermedades raras, en enfermedades minerales. Es el presidente de la Project, está asociado a la INA, que es el Human Finger in the Human, for the most important, it's very good friend. It's an expert, it's a kind of person, and they're really happy to come here, reflect, we are happy to come here because this hospital. Maybe this is not I'm sure how we are the best possible. That's it's important. So, thank you for being here. The stage is yours. Thank you. Yes, or year or that's the great honor and pleasure. The first time for me in my life to be in Chile, and I'm impressed by the beautiful country. I'm leaving this a little bit on pictures, but even here, it's totally different. And our heart is really touched by the kindness of the country, by both their mortality, like specialty care and this department of inviting us to come over and patient and it was an appetizer for us. We definitely come back and the more we always discuss these days when we come back, when we go and which will every day. So we take time, but it's worth it. So thank you very much for the session. And the topic of my talk is rigorous. But I also let the students kids grow as they understand rigorous because the technology was rather unclear. All these new forms we don't understand because they are complicated around processes. And then of course genetics change a lot. Because the phenotype looks the same, but you can't try to learn the lesson today if you look at guidance on this. You see, I'm not a surgeon, I'm a pediatrician, but it can be
Sí, pero ella no puedo mover el mouse.
I start with the cables, because we are pediatrics, so we have to look at this. Like this girl with the unremarked fibrosis, she was presented at age 18 months with no failure cry, and she hardly could move, and it's good to have a look at it. Then first, the video. And the video, and very good. Section video. Yes. Pretty cool. What you were doing. Okay, so what have we seen now? We saw the so-called deep chest. We saw the rosary. We saw the protrusion of the abdomen, and we saw the aortic sulcus and arms. We see the wrist and everything. Severe cases, the most severe cases I ever saw. The child had even fractures. You can also use or something to fracture, and you see it here the physical cupping. You see the metaphysical brain, which is typical for weakness, and so the lateral cells, calcium, there's normal phosphate, hypophosphatase, starting by pH of the starting by, and vitamin D levels, stability peaks at 1.5 is normal. So the diagnosis to what do you think? Diagnosis. I can't move forward.
What is it? Hypocalcemic.
maybe a cause? Or do you think?
Because PDH is higher,
Yeah.
it could be hypertension.
So it's there are different terms for that. So we call that nutritional rickets, yeah, because it's I learned vitamin D deficient rickets, but that's not true. It's nutritional rickets because you can get this kind of rickets due to vitamin D deficiency and or calcium deficiency. Of course, usually it goes together, but it's two different causes which causes them. And in the really industry, we met the history, so that the issue of the child was mainly based on cowbell. So they had a poor social status, and they just went to the supermarket for not infant formula, but they go to cowbell, which has almost no vitamin D in Germany, and then no vitamin D for. Okay, rickets and also Malaysia. I can't get rickets anymore. I'm too old. And because rickets is a disease of children, and it's due to alterations in calcium and phosphorus homeostasis. In the end, it's the hypophosphatemia which causes the ricket, because it's the common denominator of all forms of rickets. So the pathology is that in the end, you have low phosphate levels. This causes impact apoptosis of hypochondrocyte in growth states, which causes the impact of the cartilage markets about the apoptosis, and then we have the vitamin at the growth state. But it also affects the bone. It causes soft bone, which we call osteomalacia, which is an inadequate mineralization of the organic content of the bone, that means the osteolith. And if you make a staining, it's always the orange stain of the osteolith. And it causes in the end soft bones, bone pain, which can be very, very tricky, leg bowing and pseudofractures in the leg. This is the growth plate here, and the normal growth plate here you see there's an increase in longitudinal width with persistence of so hypertrophic chondrocyte. You see this one, the chondrocyte, and it's a carrot, the loss of chondrocyte relation. That's a nice article. It's called Hypophosphatemia, the common denominator of all rickets. Very, very good title, very good paper. But is this guy really right? Is it only hypophosphatemia which we call rickets? What do you think is enough? Sorry, I'm not kind. I asked you a question, but I want to wake you up. It's nothing is wrong or false, because it's. I want that you see also some pitfalls where I forget. Is there any other cause? I could see here. Yeah, that's right.
Hypophosphatemia is in all of them.
Yeah.
Hypocalcemia is not in the.
Yeah, you're right. Actually, when we come to that, but there's another cause, and the nephrologist should know that.
PTH increase the losses of phosphate in urine, so everyone who has rickets has hypophosphatemia.
Yeah, that's right. But beside this thing, there's another. Otherwise, we have to go back to work. So it's acidosis.
Absolutely.
And sorry, of course you know that acidosis, the protons, the bone works as a buffer for protons. So protons go in the bone, and by exchange of calcium, so you can get rickets due to acidosis, for example, children with chronic kidney disease, but also children with history related to acidosis. This is a pitfall in the road. So otherwise, he was right. All kind of rickets, but there's always another. Okay, so the diagnostic approach to rickets is tiers of the clinical presentation by radiography and biochemistry. So we have the leg deformities, where you're rapidly gain, muscle weakness, short stature, and radiography, the rapid break, cupping. Just showed you. In biochemistry, it's an phosphatase. It's so the osteoblast tries to compensate and reduce osteoblast the whole way. Like and you see sky high levels of phosphate. Then you say that's rickets. And then, as we just said, we traditionally, it's still traditionally, but it's still good for clinic. We differentiate between calcipenic, so-called, so something is going on with the calcium metabolism, or the so-called phosphorylated rickets, where something is going on primarily with the phosphate. And we can discriminate by high pTH. In this so-called calcipenic rickets, we have sky-high pTH, it's phosphatory form, and then the so-called phosphatidic rickets, it's normal phosphate. But this is a tool which I will guide you through in the next minutes. So we first have this patient with rickets, and usually we have to exclude by bicarbonate levels of chronic kidney disease first, and then we look for phosphate levels if they are low. And when I was a young doctor, I thought, I have to know what is the level of this. This was always on my desk because I had to know the level. And this is from 1898, and at this time, as a rule of thumb, 1 millimole per liter, which is 3 milligrams per deciliter, that was the lower limit. It's normal, and this is easy. And of course, in younger children, it's hard. They're always remember of the last. But the techniques have changed in the lab, and the values nowadays are much higher with the new standards. So these are the reference value we created with Hanover. Yes, as I see, it's about 0.6 higher, the lower reference, and the same holds true also for renal phosphate threshold, where you can see how much phosphate is lost in relation to the GFR and TRP. You see a nicely follow the phosphate in blood. And then you can also calculate the phosphate creatinine ratio and the calcium ratio. And if you want to have application and you want to calculate set scores, for example, let's go to the website and calculate set scores for the patients. And the good thing is these standards, as well as the caliber standards for serum phosphate, are the same. So, and they can be used also in the non-fasting state, because these standards and the caliber standard are made in children without bothering if it's fasting or non-fasting. And this nicely sets through the clinical setting. And usually in the patients who have a phosphate-wasting disease, they have no phosphate in their anymore. And then you don't have to make fasting level, because the children have to travel 1 hour and it's a lot. So you can use these standards in the non-fasting. So now we come to the beautiful world of calcipenic rickets, and we start, of course, measuring vitamin D levels. And you see that you can discriminate if it's low or low or high, and there's no anemia, fine diseases. And this cartoon you can't understand. You need to know what's going on. So when it's moved, first, what's vitamin D, and then later on you can understand it. So the vitamin D metabolism starts steadily calciferols, and the calciferols you can either get by via sunlight exposure, or you can get by dietary intake with vitamin D. So in our countries, mostly milk-based, and then you have calciferols and the liver. I don't like this term, SIP3, I can't remember, but I know as a nephrologist, you need to go to calcitriol, which is dehydroxy vitamin D. Yes, I love this term. So first comes the liver, which has 25 hydroxylates. We would use 25 hydroxy vitamin D. And this is calcium, and that's the storage of vitamin D in the body. It's stable, you can measure it. It doesn't depend on eating or whatever. It's quite good. It tells you what is about the vitamin C store which comes from here. And then later on, the kidney, the star, and this thing has the 1 alpha hydroxylase. With this, gets to 125, and then it works via the vitamin D receptor and in the body, for example, in the kidney, but also intestine, but also in the bone, which in the end has one aim: keep up serum calcium. So vitamin D keeps up serum calcium, especially in children who are growing very calcium in the bone. So the most important cause for rickets is nutritional rickets, and here you see again what we measure is the calcidiol, But there are different sort of causes. First is due to sunlight exposure, which is very easy in the northern hemisphere for us, especially in Germany, especially if you have the background, the ethical background for people, for example, come from the Middle East, they're used to long dress, exposed suns, but the German people are also like sun, but the people from Middle East, they don't to stay in the shadow. And they make it. And nowadays, even in Germany, we have indoor living, children don't live outside, and that may cause low levels of calcium dioxide. On the other hand, as a child, you see that funny dietary habits, so we also can cause by diabetes. So this causes low levels of vitamin 5, and this causes calcium absorption, and this can make a slight drop in calcium. They don't have hypocalcemia, but calcium goes down a little bit. And this can also be caused just by low calcium intake. So the vitamin D and low calcium intake meets here, and then the story just follows the rhythm. There's the parasitic gland. Low calcium is not good at all for the body. If you have low calcium, you get cardiac arrest, you get seizures. So the parasitic glands are what? No, I don't like that. So we produce PTH, and it can go as high as it must. And this is very good because by doing this, the 1-alpha hydroxylase gets activated, and it also mobilizes calcium from the bone, and it makes sure in the kidney that you preserve calcium, but at the cost of phosphate wasting. So you keep up calcium in the blood, but you have phosphate wasted, and then you have low phosphate, you get a letter of all kinds of pills, and then you get rickets, and then you get accumulation. And this system goes as long as the bone is empty. And when the bone is empty, when you get calcium, that's left. And then you get low calcium, and then you get seizures and diabetic cardiomyopathy. And this here is from a girl who really died because of diabetic cardiomyopathy. This is a very good review on the residual lipids from Uda and Volta from Linz in Austria. And this is excellent. Just read this paper. This is wonderful. Okay, it's easy to treat. So you give either daily doses of vitamin D or make a so-called Schulz therapy in parts, whatever you like. Please remember, ensure adequate calcium intake, and especially the young ones who are in disease, you have to add calcium in the beginning. There are other funny forms of calcium-killing lipids, 1A, whatever. I don't remember this. After my talk, I completely forget this. So what they will have in common? They have in common, they have star levels of phosphate, and they have star levels of pH. And you can see 125 and 125 varies, but you can't understand this like this, so we go back. Oh, and one thing is the type 2A, the children present with alopecia, so they get diagnosed. So we have to go back to the pathogenesis to understand when it's 25 low, when 125 low, or whatever. So if the 1-alpha hydroxylase doesn't exist, it's a very rare disease. You have enough calcium. So this is normal, but 125 to have a lot of 25. If in the liver, the 25 hydroxylase does not work, then you have low 25 and you have low 125. If the receptor is not working, the machinery works. You have normal 25, you may have even increased 125, but it doesn't make a difference because the receptor is not working or the signal is there. And then it's just one patient presented in the world, like always. It's a funny disease where the degradation of calcium is increased in the liver. So the degradation is done in the kidney, but it's also done in the liver. And these patients have a degradation of 125, which in the end, the body is running out of fuel of 25 and 125 because everything goes away. And then you treat them according to the diagnosis. You understand the metabolism, you know what to do. So in these patients, the 1-alpha is not working, so you just give it as a trial because it's missing. Here, the liver is not doing the continuum, just give continuum. It's very easy. And here, the receptor is not working. The signal, so we just anhydrose it, has to go through a train. Hopefully, this child is not getting a seizure and hopefully not getting an electrical sclerosis. And then the vitamin D receptor. Here, I have never seen. They say, well, we give anhydrosis of vitamin. So we move forward. Now we come to the lovely world of phosphatenic rickets. In the phosphatenic rickets, we say we have renal phosphate wasting, or we have a lack of phosphate, but it's not due to pH. And one pitfall, sometimes if you do the history, you know that, but you may have no phosphate in the body because the intestine is not doing well. So we have short bowel syndrome, or we have some kind of increased gastric absorption. These patients have low phosphate levels, and how do you get that? If you calculate the TNP over GFR, I love this formula. In the morning I wake up, what a lovely formula. But this is a pitfall because if you don't have intake of phosphate, or the bowel is not working, then you have nothing phosphate left in the body. But the formula we are using is you substrate what is lost in the urine from what is in the blood. And if you have no phosphate in all the body, the serum phosphate will be low, and the formula will force the below. So if you are in this thing, there's not measure TNP over GFR, measure urine levels of phosphate. And that's why I showed you the reference ratio. So if the phosphate trading ratio is very low, there's no phosphate. So obviously something is moving. That's just a picture. Okay, you did this, and then you move forward, and then this is a didactic cartoon. In the new guideline, we also have a cartoon that you can differentiate without measuring frequency. But it's for didactic reasons, it's important to know that's another phosphatory hormone called PTH is also fibroblast growth factor 20. And before we go through this road, I have to explain to you the most common cause of FGF23 mediated hyperphosphatemia rickets is the extreme hyperphosphatemia. And it's an interesting story. So in 1837, the all-widely described vitamin D resistant rickets even to high doses of vitamin D. What's that? It's not reacting. And then in 58, it was clear as an X-linked dominance, inheritance. And then even persist after a kidney transplantation. There's something in the blood because we have a healthy kidney, and it's still again phosphate wasting. And then in 95, the PEX gene mutations were explained. And at this time, I was taking care of children of XOH, and I asked my professor, I don't understand the disease. Go to the library, there's a book on XOH, the usual. And I read the book the weekend. And I went back to my professor and said, Professor Mears, I do not understand. I recommend to read the book twice. Now I know that he also didn't. I looked at the book and said, there's nothing left to see. So again, the story went on. So there's also PEX mutation for vitamin D resistance phosphorylation in adult. And then the story started. FGF23 were cause mutation in so-called autosomal dominant form. That means that the protein FGF23 can get degraded. And later on in 2001, high levels were associated in tumor-induced phosphorylation and 2,T and XOH. And then there were anti-FGF23 antibody which cured rickets in hip mouse. It's an animal model of XOH. And then the first clinical trial with the antibody, and the antibody is Buldumab. And then there was a registry, and then approval of this drug in Europe and America. And then we have made first clinical practice certification, published in Nature Medicine in 2019, and then it was approved for adults and then in 25, just recently we updated the data. So this is XOH, is the most common inherited cause of hypophosphatemia rickets. And I just showed you again the pathology, so that's the explication. We don't know how it works. It's a lack of antibody base, but we don't know the substrate for that. But in the end, we have an increased synthesis of active phelix-3, which tells the kidney we don't need phosphate, get rid of it. And first of all, there's a down-regulation of the sodium phosphate, sodium-dependent phosphate transport of the kidney, and we can tell them one alpha drug cells, we don't need you. Stop. And if this you lose phosphate, and if calcitriol goes down, in the intestine we have less phosphate via absorption, and we end up with low phosphate again in the So the main systems is starting in the first 2 years of life, this was short stature, rickets, and osteo and photoglomatorization, because the PEX gene is working in the osteoblast in the bone, but also in the teeth. So we all have teeth problems come to that. What did we do for decades? We just substitute what's lost. So we give tons of phosphate 5 times a day. We give high doses of calcitriol, and it works not bad, but there are side effects and for calcinosis and hyperparathyroidism, and it's like the Cold War. No one can win. It's better than nothing, but we were always not happy. And the patient came into the outpatient clinic was always not a happy situation because the children are not doing well. Change will be calcitriol, it will not change anything, but change a little bit, but not, we were not happy. Now with the Urosumab, it completely changed, and with the treatment, you can really almost cure the rickets. So if you look at the X-ray, they almost look normal, and it was a randomized trial showing that compared to conventional treatment, substantially better for healing, but also for physical function. And before that, the children were like that. And now, and I always went you round with them, and nowadays they are faster than I am because I'm happy before I started and so on. So it's complete change. But if you have a patient showing up, you may also see that the trunk is rather conserved and they have short legs and long legs. So you can see that from far away. And you may also depict the frontal fossa here. And they tend to have a Deutsche cephalus because bacterial fluency also works on the sutures here and makes premature dosing of the suture with Deutsche cephalus, and the children also have transistosis sometimes. So you have to be aware of that. With Urosumab, everything is better, but the disproportion still keeps going. So the legs are straight, very good, they can run, but the disproportion short stature gets a little bit better, but at the root part they are still. Then the root teeth. The children, at first glance, the teeth look normal, but it's the odontoclasts are diseased, and the dentine is not growing. So every one of us has small cracks here on the teeth, and the bacteria go to the dentine, and the dentine is weak. The bacteria go straight through, and the teeth look normal, and they never move that's a typical sign of all kinds of hypophosphatemic rickets form. So you don't get this in calcific rickets because in calcific rickets you don't have a pathoplasty. So that's what is different. Okay, so FG23, you can measure it, and there was a study, and I studied in the US, they showed it's the intact active protein, that's the biologically active active is above 27, has a 100% sensitivity, and has a phosphate active driven rickets form, and also tumor induced. But what's 27? People read the middle, what's that? Doesn't come from God. Sorry, I'm not. What is the jokes about God? But where does it come from? It's so beautiful. Nature is so beautiful. It's a regulation process, and we did another reference study also at the level, versatile. That's interesting, but the most important thing course, when we compare the 27 to the reference values, we see it's just the 3rd percentile. So if you have the child with hypophosphatemia, the FGF23 levels should be suppressed. If the levels are in the normal range, they are inadvertently normal. And in the cartoon, we showed in 2019, the first guideline, you remember, there's really high FGF23. In the new guideline, it's not high FGF23, it's inadvertently not suppressed. So the patient with hypophosphatemia, FGF23 level must be suppressed. Otherwise, there's something wrong with the treatment. And this is the new guideline. It's really nice that it's 4%. It's better. So later it's really important. So we have different forms. They look clinically the same, but they have a different inheritance: dominant, X-linked dominant, and recessive. And their own causes in the end the increased FGF23 expression. Here's the cleavage there. I'll come to that in a second. And they, in the comparison to the heterogenic lipids, alkaline phosphate is only moderately increased, and PTH is also increased, but it's not sky. You can see by the value alkaline phosphate is increased and PTH, but that it never can be. They always have sky. Okay, the autosomal dominant hypersensitivity is a very funny disease. It's usually the children are not affected. They have the disease, but it's usually in the females when they start with menstruation, so they have a monthly bleeding. So they tend to have iron deficiency, and this iron deficiency has something to do with FGF23. So if you have isolated iron deficiency, you have a little bit increased transcription of FGF23, but you also have an increased cleavage. So in the end, there's no change. It's academically interesting. If you have the disease, the FGF23 can't get degraded because we have a mutation here in this protein, in this amino acid, where the cleavage takes place. So usually in these patients, you just get degradation of FGF23 active, and you just have more C term, and the C term is not biologically active. So it's not active. But if you have the combination of the disease, autosomal disease, and iron deficiency, you have increased transcription and decreased cleavage, and then you end up with high levels of FGF23. So in any patient who is presenting with wicked after the age of 3 or 4 years, they will this kind of disease, especially in females. And it's very easy to treat. You don't need pulsar. You just add iron replacement, because this is missing in this patient, and then you substitute the iron source, you reduce that with calcium phosphate goes nicely, and the alkaline phosphate. So there's another tricky disease. If the patient manifests after the first 2 years of life, excludes trying very best and the tumor genes of Malaysia, and that's tumors you are expressing as different. As here they are, it's benign medicine child tumors, which can be an nightmare. They are a soft tissue that will do FGF23. And the first symptoms are beyond childhood. There's a negative pregnancy, and there is severe pain. It's progressive. So they were healthy until Christmas and Easter. They're like that. It's very clear, and they have very high levels of FGF23. And yeah, the fun is to find the tumor. So we need all this imaging. We discussed in the hospital what is available, and luckily we find the tumor like here, and it's fine. And the goal is first to start with what is available, which is good, but you have to get rid of the tumor, and there are also other new drugs around the block. Okay, we end with a final case. It's a 3.5 million with kidney stones and several maternal heparin glands. It's very good. Her height is decreased, the weight is decreased, and the bowing of the leg. They noticed at the age of 18 months that she did this cowboy and going, she trips and falls, and running, sometimes on Carry even speak for other people. Normal teeth and normal hearing. Hearing is also speak about and then you come to the lab result. Calcium is normal. Phosphate is decreased. I think phosphate is decreased. pH is normal. 25 is the normal range. 125 is the upper end. TPOGR for fluid is already used. And then we calculate effective between ratio, we need to 7.9, and they are all markedly. And then the ultrasound scan, there's no level continuous or stroke. What do you think is the diagnosis? Or maybe the diagnosis? We don't know about it. Yeah, that's a good thing because I did show you the tool. It's formed by the NAPI, the sodium phosphate transporter do not work, and then you have no active speed, but it's low, suppressed active. Then 125 goes up, which causes increased calcium absorption. So that's so there was the whole panel. So that's the hypophosphatemia rickets genes, and that's the hypophosphatemia gene. And no pathogenic. That's why I showed you. So how to move on? I think you all know it's the kind that children get presented at the fall. And if you get a cold, it's a different setting if you come to the hospital. You do by doing our own rhythm, and you don't forget things because even if you're sleepy, you just do everything. But if it's coming from outside, sometimes people forget certain things. So in the dipstick, and there was a generalized evidence theory. There was no but bicarbonate was already low. So it's a beginning from global syndrome. And it's a typical pitfall for giving it was cystinosis, of course. And cystinosis also has a career. And at the beginning, sometimes the children just have little bit rickets, nothing else. There is all things on it's an exhalation, but they really happy. It's a lovely disease as a this is a blood boy. This is a blood boy. Have you checked the urine? No. I think it's X-ray, believe me. And then it's the noticeable wrong. And of course, this is this part here. Your doping and difference is suppressed, and then the noticeable wrong. And as you know, the other nice disease, or interesting disease, causes according to cystinosis, wrong. I think again that's idiopathic because we have gene transfer and species that are characterized by the bleeding with glucosuria and minotubular acidosis So of course you always check this. You can do this in different ways, but also and then there's also again acidosis. Okay, that's my talk, and that's not our hospital, unfortunately. That's our hospital, and that's our come to the Nova. It's always nice to have a lot of fireworks in the summer, and you see people always. It's a barrack garden, but something is wrong on this side. I realize it later on. If you are somewhere in the world, you always want something you don't have at home, and what we don't have. Palm trees. So the former king who had kicked us out because it's our garden, but we have palm trees. But in the winter, they go inside this building. So thank you very much for your attention. Thank you for your result. I was thinking about the first year test you showed us with the visual effects. The lab test showed very low vitamin D levels, but in 125 it was what is that? 125 levels, but I trust. because they are highly variable. Their reference values, the assays differ. So when we do clinical studies, we always measure them by our state-of-the-art assay, and then we have to them. So even if you have a tiny level of 25, the body is still able to have some 125 around in the blood. But it's usually it doesn't go down. And one cause of this PTH. So PTH increases the 1-alpha approximation. So it compensates. So we get phosphatidylate. But PTH also keeps us with 125. So despite the severe deficiency, we have still some 125. So 125 in clinical practice is a very difficult thing. And in the hypophosphatemia, you may have increased, but sometimes they are not. So I think it's the PTH which comes. And the peripheral levels may not present what's going on with the patient. But you're right. I'm already also struggling with that.
Sorry, two questions. I think one comment, one question. You mentioned acidosis in those patients. And I think physiopathology is dangerous sometimes when you have the patient in the beginning. Because I discussed with my colleagues from endocrinology that they say, well, we're kind of forced, so leave the acidosis, it will correct later. But I discussed with them, let's normalize the acidosis because it takes too much time to correct it. For example, in a patient with hyperparathyroidism, and then
first, I fully agree. Correction of acidosis it's a goal.
Yes,
because if you have
you don't have the cause, because in the first
it doesn't matter for diagnostic purpose. If you correct it anyway, it doesn't matter. It doesn't jeopardize your diagnostic work. And if it persists, it's not so easily do. I fully agree.
Let me
Sorry,
no. Let me tell you about one case of cystinosis. These patients in the first visit, they cannot move. They cry. They have pain because of fractures, and that's terrible for them. Sometimes you don't have cysta bone yet, or if you correct acidosis, even in nutritional rickets or calcipenic rickets, the patient will feel better, maybe less pain. So it's crucial to treat acidosis in this patient.
Absolutely, and I think usually what we do is we do the workup, make the tests, if we like, say, if we like, and then start treatment. And then later on, that takes about a lot. But we start treatment, we don't wait. All genetics will take 8 weeks, so we come back. So we start, and the child gets back. Because you know what to do, you substitute with phosphate, for example. And if it's a little bit looking like XLH, we play, and then you have to discuss with family, to mark insurance, and maybe start with a conventional. But if it's obvious that 2/3 of patients has a positive family history, you can start with those marks.
I'm happy with your answer, and I asked everyone, please treat acidosis until recurrent of sour cake.
Yeah.
And the second,
and it's always treated right.
Yeah.
So it's not in dialysis patients. We are sometimes happy if it's about 20, but usually it's 21, 22. Yes.
Second one is a question. Even in Germany, when do you ask for genetic tests for these patients? Because sometimes you have everything clear? Do you ask for everyone when you have rickets diagnosis, or do you?
If it's a picture compatible with nutritional rickets, you don't.
Okay.
If there's a history of XLH and we know there's a gene, then we may confirm it, but it's not necessary. But usually in the algorithm I showed you on the bottom, genetic testing. So usually, even it looks like XLH, we might be autosomal recessive. And for genetic, it's not mandatory, but for genetic counseling, it's first, that. And the other hand, if you give a fancy like you should know what you're doing. The autosomal recessive form 2, you are not allowed to give full because they also get calcification of the vessels. So, there are 3 patients in Germany. And on the hand, they were treating someone, but I don't want to start doing the modifications which may have this one. But it's a matter of resources, of course. It's not mandatory, but if you can do that, then you always do the panel lab. Nowadays in the lab, you have the panel lab also. And this makes me sometimes angry. There's a patient coming in a little bit like hypophosphatemic, and they say, yeah, we did all the tests, and what do you do? If you look at the paper, and oh no, the genetic comes back in 2 weeks. We get it very bad. They get angry. Yeah, don't be out with them, make sure, because and then you get back the results, pathogenic variant of unclear significance, and then they start this. It's unclear, and then maybe it's still a disease. And then did you make the burger? No. So it's a matter of resources, and if you have available help, and people shows what you are doing, and sometimes you learn something. But it's not always mandatory. I think the algorithm I showed to you explains most of the cases. And in the new XLH guideline, when we go through, we end up in the end with the FJ23 driven hyperphosphatemia rickets, and we also exclude hyperphosphatemia hyperphosphatemia. So there are only 3 diseases that the XLH is the most part. So you can even go without a fit transfer to the algorithm and make 90% sure that it's hormonal. I love genetics, but it's so mandatory that you understand the disease, because later on we need to. I really get upset if we were way just for that. Sorry for my wife is being into that.
My first question with age, it's was diagnosed in 1996. So now he is 88 years old. 4 years ago, he had a heart attack. So the doctor has disease because he has rickets. So the question is, I will begin with the treatment with this month in the tower when she was 3 years old. But I wanted to begin with the treatment when she was 1. And why the guidelines say you have to do the treatment after 1 week old?
Because it's a legal thing. The trials, all the patients after the age of 1 year, so there are 2 groups, 1 to 5 years, and then 5 to 12. So it was never tested for legal reasons. It's not licensed. And it's expensive. It's enormous. You can buy a Ferrari every Porsche. So for legal issues, you're not enough. But now there's a trial. I think in the years we have medical investigation, and it also works in the younger infants, and there was a safety board, and now to say there were no safety issues about this works with children. So soon with even then we can start. And that's really pity, because the mother has an older child which pulls them up and poison the infant with phosphate, etc. Then all bad memories comes back to the mom. Oh, look, I think the diarrhea. Oh, can we? Then we don't have to wait. And hopefully, maybe next year, hopefully, available, and then usually I think it's
started, I don't know the weeks, at least 30 neighbors. So,
Well, thank you, Dr. Hadley, for your conference. Very interesting, very clear, very interesting.
thank you very much.
So, for your presence, Laura, thank you very much. Yeah, well, y por todo, muchas gracias por la presencia y no hay más preguntas. Nos vemos el próximo miércoles. Thank you very much.
Thank you. Thank you.